So remember, when anyone gives a talk, they have to outline potential conflicts of interest. I will do my very best to be completely objective, but we are going to be discussing data. I do sit on advisory boards. I have done paid lecturing for companies. I do work in non-NHS clinics, and I think now as we touch on treatments that are not commissioned in the NHS, I think it's important that I put all potential conflicts up there. So the talk structure, we're going to have an overview of leukemia and CLL. We are going to talk a little bit about the advances in laboratory diagnostics, some CLL supportive care issues, and then we will, of course, go on to therapy. Now, when I've given this talk before, often questions are triggered as we go along, and I've been pointed out that if someone asks a question from the floor and I reply, it's then quite hard for everyone to hear. So perhaps write down the questions, and then we can have a question and answer session at the end, and I will repeat the question as I give what is my view of an answer, if that's all right for you. So forgive me, those of you here 2 years ago, there is a bit of overlap. The talk does then change, but I apologise. I have to do the introduction, which hasn't changed enormously. So what actually is leukemia? Well, leukemia is a cancer of white blood cells, without stating the obvious. And this picture here is giving us a feeling of the mother cell, these pluripotent stem cells that sit in the bone marrow, and they differentiate through. They become the more mature cells of the myeloid system. You chaps can't hear at the back, can you? There's a lot of interference. All right, go on. I think it's doing 2 microphones at the same time. Right, there we go.
Now, where's Mark? I need now, I don't know which I'm got it on, because it might, just try it. Is that better?
Hello.
Is it on? Where's Mark gone? I haven't got my glove. Yeah, it is. Just talk now.
Hello, hello.
Just talk. You have to hold it quite close to you.
Hold it quite close, right. Oh gosh, I feel like I'm now doing an after-dinner speech at a wedding. Well, the bride looked lovely. Right, back to more routine things. So, pluripotent stem cells, they sit in the bone marrow, they live our lifetime and occasionally renew. They're critical to our blood system, but they spin off the cells that become our red cell series, platelets, the neutrophils that your doctors are always talking about in clinic when you're on chemotherapy, and they also spin off the lymphoid system. And the myeloid leukemias come from that lot, and the lymphoid leukemias come from that lot. And you hear people talking about acute leukemia. That's normally when a more primitive cell goes wrong and it packs out the bone marrow, sometimes spilling into the peripheral blood. But the acute leukemias patients can be completely well, and then within 2 or 3 weeks become precipitously unwell, life-threateningly ill. Whereas the chronic leukemias are all diseases of the mature cells of the blood system, and they tend to progress much more slowly. So that's why chronic myeloid leukemia, chronic lymphoid leukemia have a very different type of presentation from the acute leukemias. So chronic lymphocytic leukemia, what do we know about it? Well, it's the commonest leukemia in the Western world. These so-called clonal blood cells, so they all derive from one abnormal cell, they accumulate in the bone marrow, they spill out into the blood and they swell the lymph nodes. So patients develop lymphadenopathy, bone marrow packed with the cells over time, and also and the consequences of bone marrow infiltration. So this is just a diagrammatic representation. So lymph nodes, packed out bone marrow, and then the cells spilling into the peripheral blood. The cells, when we put them through the analyzer, have a very characteristic appearance, and that's why diagnosing CLL is rarely a challenging diagnosis. If you have a lab that's basically set up with modern diagnostics, they have very specific proteins on the surface, and the proteins, we give this code, CD, it stands for cluster differentiation, and it's an old-fashioned terminology that refers from the days when we used to use antibodies and serology testing. But the proteins have a code, so CD5 pos, 23 pos, and relatively weak CD20. And that's a hallmark of CLL. What is a typical patient like? Well, it's a disease of the elderly. So typical age of presentation is around 70. Of course, we have some very young patients who present and some extreme elderly present, but that's the average. There are more males than females with CLL, and it does tend to cluster a little in families. Now, I'd say to patients, remember that 4 times higher risk with a first-degree relative. If you just, for sake of argument, pluck a number and say your lifetime chance of CLL is, say, 1 in 4,000, well, that means a first-degree relative has a 1 in 1,000. So statistics can say the wrong thing sometimes, because 1 in 1,000 still means they have a 999 out of 1,000 chance of not getting it. And that's why it's very important this is not Mendelian inherited genetics, where if your brother's got it, you've got a 50-50 chance, or if it's a recessive, you've got a 1 in 4 chance. It's nothing like that. There are just a few families where there is more familial clustering, so it's a bit more complicated than that. But as we know, many patients with CLL are found coincidentally. So it's the typical patient, maybe they've retired and their wife says, you haven't been to the GP for 20 years, go and get a check. So they'll go and they have their blood pressure checked and their cholesterol, a full blood count, and lo and behold, the GP's ringing them and saying, you've got leukemia. What a disastrous start to their retirement. But that type of thing happens. So it's the well person who's had a blood test, sometimes for relatively soft reasons, that uncovers the finding of CLL. But this emphasizes how benign CLL can be for some individuals. And I've put this phrase here, monoclonal B lymphocytosis. That raises a lot of questions. It is just CLL, but at an even earlier stage. Because if we went out into Cambridge and found everyone over 70 or 80, took their blood and put it through an analyzer hunting for little tiny low levels of CLL, it's surprisingly common how often you can find it. So there are some people who think some clonal B-cell expansion in older age is just part of the normal aging process. Now, of course, that's not CLL, and so those patients have been given this separate label, monoclonal B lymphocytosis. Because doctors, we like to classify. We can't just say they're normal and they're 80 and stop doing the test. But as we know, CLL, is it the pussycat or is it the tiger? And that's the problem, because often at diagnosis you don't know, and it can cause a lot of stress for patients because they don't know whether they're at the beginning, this incidental finding, if they're relatively well, but patients can, of course, present with more systemic symptoms and they can develop them. So what might these be? Tiredness, weight loss, sweat. Tiredness is such a challenging symptom to try and unravel. I genuinely suspect most of my patients with even early stage CLL are symptomatic from their tiredness, because it's such a common theme. And another recurring theme is when you treat patients, how quite often, 1, 2, 3 months into treatment, they'll turn around and say, you know what, I'm finding the treatment difficult, but in myself, that deep gnawing tiredness that I can't get rid of seems to have got better. And that's a recurring theme, which means I suspect many, many patients are symptomatic with it. And if you had a tablet with no side effects and you could say, just take that for 3 months and see if you feel better, I suspect we would do that. But we don't. But I think it's just an observation that tiredness, very challenging symptom. As CLL advances, patients can develop bone marrow failure. So that's when, in simple terms, the leukemia packs out the marrow. So the normal bone marrow function, remembering the bone marrow is the factory that produces the blood, so that normal bone marrow function is pushed to one side. So patients become anemic, they can become neutropenic, the healthy white cells fall away, and they're more prone to infection. Occasionally patients can bleed. The lymph nodes become enlarged, and again, very different symptom profiles. Sometimes the lymph nodes can be uncomfortable. Thankfully in CLL it's quite uncommon for enlarged lymph nodes to squash kidneys or liver or cause extra problems. It can happen, but it's thankfully uncommon. But the nodes are very variable. You can have, I don't know, I don't sound sexist here, a 70-year-old bloke who doesn't notice he's got big lumps left, right and centre in his neck. And if you're a 50-year-old woman, I don't know, trying to carry out business meetings, it might be very upsetting having prominent lymphadenopathy around the neck. So there's a lot of variation between individuals. Splenomegaly. Spleens can enlarge and push on the stomach so people can't eat properly, can give them discomfort moving around in bed. I've come across all presentations of how splenomegaly can be troublesome. And an enlarging spleen can take cells out of the blood, so it can contribute to lower platelets, contribute to more anemia. And unfortunately, as many of our CLL patients know, recurrent infections is an ongoing issue for CLL because the immune system does gradually fail with CLL. As that clone takes over in the marrow, it does compromise how you respond to different infections. And as part of that disturbed immune profile, CLL patients have a much higher incidence of autoimmune complications. So that's destroying the blood, something called hemolytic anemia, chewing up the platelets, but also some strange skin autoimmune problems can crop up unexpectedly. But CLL itself can follow many courses. You can have the very slowly progressive disease, you can have much more aggressive disease, you have others where the counts will come up and then just sit there. And you don't really know with an individual in your clinic until you follow them, until you've got bloods over months, even years sometimes, as to what the course is going to be. And this throws up so many questions, and it is very challenging at the beginning for patients. You know, the word leukemia, how long have I got, doc? That question is asked. Some people, they're very, very unsettled by this word. How unwell am I going to make me feel? Because if you're well and you've had a blood test and you're sent up to the oncology clinic where you're surrounded by people in the waiting room having chemotherapy, you're primed to go into that first consultation with your doctor assuming you are going to become very unwell. And you can see all of these unsettling aspects about CLL at the beginning. And so all of this leads us, as patients, as clinicians, we would all love to be able to have an active way, or an effective way rather, of predicting with that individual how well they will do with CLL. How difficult is their CLL going to be? But of course, is that a good thing? If you're 75 and well, is it better for you to say, I'm well? And when your doc says, I'll see you in 6 months for a routine check, or you know what, back to your GP because our clinics are overrun, is it a good thing? You might be best to just walk away from it. But you might be a 60-year-old businessman, businesswoman trying to work out, should they sell the company? What should they do? Should they change their pension plans? And you can see why a lot of people might have different reasons for wanting to know how good or bad their CLL is. And we can come at this problem trying to predict for the individual with the most basic, which is the simple clinical parameters, and more complex laboratory parameters. So the most simple clinical parameters are the staging. And the Binet stage is what we've tended to use in Europe for a long time. It has the huge advantage of being incredibly simple. So stage A CLL, you are not allowed to have lymph nodes in 3 areas. So you can have neck and groin or neck and spleen, but if you've got neck, spleen, groin, you can't be stage A. You've also got to have hemoglobin over 10 and platelets over 100. So it's really quite simple. And stage C is if you're anemic or thrombocytopenic. So very easy, A, B, C. And these are old survival figures, old figures, before we had any effective therapies really for CLL. The Americans have complicated a little with their RI classification, which we use in clinical trials. Platelets are dominant here, so if you're thrombocytopenic, low platelets, you immediately jump to a RI4. And you can have as much lymphadenopathy as you like, as long as your spleen isn't enlarged, then you're only a RI1. The only real complication this makes is cross-comparing clinical trials, but I think we'll just park that. So, laboratory prognostic indicators. So there's a huge area of interest trying to separate these things out, because not only can we use them to predict how well an individual will do, but can we use laboratory tests to extend that further and work out which patients are more likely to benefit from which type of treatment? So if you've got this profile, should you have those drugs? If you've got that profile, should you have the other set of drugs? And as you might imagine, there's a huge amount of interest in that. So in terms of laboratory things, I'm just going to stick with 3 very clear areas. So one is immunoglobulin heavy chain mutational status. And if you're new to CLL, sorry, that sounds a great mouthful, but I do have a few slides to try and explain that. Chromosomal abnormalities and mutations in specific genes. So bear with me. So imagine you are sat inside your lymph node. That is my artistic skill of a lymph node. Into that lymph node comes primitive new B cells from the bone marrow. So it's being populated by the new cells that come in. And this is everyday normal life in your lymph node. An immature B cell that has the potential to recognize any foreign bug. That's how the immune system starts. It goes in as an immature cell and it is unmutated. So the immunoglobulin chains have not been refined to recognize anything specific. Because our immune systems, this is a feature of higher biological organisms. We've all got this amazing capacity to start off being able to see anything. And then through the randomness of realignments in biology, we can see any combination of bugs. It's why if a new pathogen jumped from outer space that no human had seen before, yeah, I'd probably kill off 90% of the planet, but 10% would survive because of the random amazingness of biology. And what happens is these immature cells, they go through the germinal center, which is in the lymph node, where they see the foreign proteins and the bugs, and through that random interaction, the cells are saying, do I recognize you? No, I don't. And some of them are killed off. But the ones that partially recognize a foreign bug are then triggered to refine. And those immunoglobulins then become mutated. So these are mature B cells. So hematologists and immunologists talk about pre-germinal center B cells and post-germinal center B cells. And that's a very important thing because those mature cells are the ones that are recognizing specific antibody. And CLL can come from either the immature B cell or the mature B cell. And actually, if we were starting from scratch, we might choose to call CLL two different names. Well, actually, we do. We call that one unmutated CLL, UCLL, and we call that one MCLL. And the reason it's important is because the unmutated UCLL is a more rapidly dividing disease, it's more likely to need treatment, and after immunochemotherapy, it's more likely to relapse early. And mutated CLL is exactly the opposite. So that is less rapidly dividing, less likely to need treatment, and these are the patients that can have very long remissions. And this is a feature of CLL that is with the patient for life. It does not change. The CLL either comes from a primitive cell that's unmutated or from a more mature cell. And this is a very old survival plot from Terry Hamlin, who was one of the forefathers of research in CLL, published 20 years ago now, just showing over, we've got 10 years here, 20 years of follow-up, the actual numbers of patients alive. This is way before modern therapies, and this is the first time I've shown a Kaplan-Meier survival plot. So let me orientate so survival are up on the y-axis and time on the x-axis. So if you go along the 50% line and you come down, so half of patients are alive at 10, 11 years, well, 10 years with unmutated, but mutated CLL, you've gone out to 20 years. So the next thing we talked about was chromosomal aberrations, and you'll see whenever you read literature or people talk about CLL, they talk about their chromosomes, so 17p minus, trisomy 12, 13q. What does that mean? Well, humans, we all have 22XX or 22XY, and that is a normal chromosomal makeup. And if you're super sharp and got good eyes, you'd realize that this is a Down syndrome child with trisomy 21, and it's a female, because that's what we call a karyotypic spread. And you can get abnormalities of these chromosomes in the CLL. And to stress, this is not an abnormality you're born with. It's the CLL, as part of its mistake, the genetic process that's gone wrong, has acquired abnormalities of its DNA. So trisomy 12, 3 copies of trisomy 12. Very common abnormality. We know that tends to associate with specific mutations and specific clinical characteristics. 17p deletion, this dreaded 17p minus, that's when the P stands for petit, sorry for my Leeds Grammar School accent there, but the loss of the short arm of the chromosome 17, which associates with loss of the TP53 gene. And it's loss of that gene which means that those cells are not killed by chemotherapy in the normal way. But there are a collection of others. 13q, so that's the short arm, the long arm of 13 that's been deleted. That one actually associates with better prognosis, and those patients tend to do better with immunochemotherapy. 11q minus, those patients tend to have quite bulky lymphadenopathy. Before rituximab came along, they used to do as badly as 17p, but they have a disproportionate gain from using rituximab. So you can see all of these little characteristics that we're getting to understand from all the research and the clinical trials that help predict how patients are going to do over time. And this big complicated colour spread at the back, you probably can't even see, but at this end, this is looking at survival of German patients going into trial, but this is before rituximab and all the new drugs came along, nearly 20 years ago. And again, here we've got very poor survivals. Patients with 17p deletion, only half of them alive at 3 years. All the way across the other way, we've got 13q deletion, where tracking that all the way, you've got 10, 11 year survival. So very big differences in disease biology. So we did immunoglobulin mutation status, we've done chromosomes, and then the last thing is mutations of specific genes. And I'm going to keep this very, very light because it's a very complicated area. But mutation of TP53 is the key one that we should all be testing for now, and that is agreed, internationally agreed, and within the UK, before patients start chemotherapy. Because mutation of TP53, so this is the gene that sits on the 17p chromosome end, that if that is mutated, you just don't process chemotherapy in the same way. The cells are just not killed off by chemotherapy. So we do need to identify those patients because they are better treated with other modalities. But across the 20,000 genes in your genome, as you might imagine, many of these are mutated in different cancers. And I hesitated to put this up, but I just wanted to show along here is all these different genes, and then patients who have alterations, and then we're doing a lot, well, Anna Hsu is coordinating in Oxford, a lot of deep dive research trying to find out which patients are responding to which chemo. How do you classify non-responders, early relapsers, to try and map out correlations with mutations of different genes. So there's a huge layer of complexity that we do not bring into the clinic at the moment, but it's another thing that we can classify. So that was deep dive, and if you're not really into your CL biology, don't worry, we're going to come back to a few more simple practical things now we've stepped back from the biology. But in simple terms, what is good? Early stage, mutated immunoglobulins, 13q deletion is good, no evidence of 17p deletion, and no mutation of that gene, the TP53, and exactly the opposite is less good. So, when do we treat patients with CLL? This is a big discussion, and it's different a little bit in different countries, but we must remember a few key points. So CLL with conventional therapies cannot be cured. Now that's, of course, a terrible statement, but as we know, you can live with CLL with very good quality of life. Of course, it has all the extra complications that come with it, but many patients diagnosed with CLL in their 70s will have a normal, natural life expectancy. And I do stress that to patients, and patients diagnosed younger than that. But if you've never had a trial that shows survival benefit, treating patients early who are well, as a clinician, it's very difficult to give someone treatment that any treatment can give them side effects and make them feel less well. So if a patient is well with CLL, the international standard remains that you don't treat them, and you put people on this dreaded watch and wait. But that is still the international standard of care. And of course, you get all sorts of views. You get fantastic. So you get some patients who come in and says, oh, I thought I was going to have chemo. Right, brilliant. I don't need anything. Great. See you in 6 months, doc. Because that's how some people cope with disease. We also get the other, oh my goodness, how can you let my cancer get worse? You're just going to sit there. They drove in their car and they heard on the Today programme, cancer survivals are terrible in the UK because of late presentation and all these other things. And then you're trying to say, well, you were really quick, but I'm now going to slow it all down. So you've got a bit of work to do to try and put that one. Is this the NHS saving money? So of course, that one either comes up from them or it comes up from their son when their relative's gone. Surely, the other one was, would this be happening in America? I should have put that one down there. But I put the passage of time here because it is quite interesting that with CLL patients, quite often the ones who are really pretty fired up about wanting to be treated with a lymphocyte count of 7, you give them 3 or 4 years and the lymphocyte count is 30 and they've got some sweats in their nose and you think, you know, maybe we should think about treatment. And of course, there can be often a complete inversion. Why would you want to treat me? Oh my goodness, I'm absolutely fine. And their wife or husband's looking at you going, he's ill. And so you can have that inversion from being really keen for treatment to becoming less keen, and of course the other way around. But all individuals are different. Supportive care. It's very natural when you have something seriously wrong with you. All human beings want to do something themselves. Of course you do. And they say, there must be something I can do to improve this for me. Well, keeping fit. We all know we should keep fit. We know that. That's why I say to all my patients, keep fit, because when it comes to treatment, that's very important. Look out for infections. Act early. If you have recurrent chest infections, it might be right for you to have a pack of antibiotics at home. We call that a rescue pack. If you have proper recurrent serious infections, in our clinic we refer people into the immunology service, because immunologists do all sorts of things. They check all the serotypes for different bugs, and they do vaccinations and trials of rotating antibiotics, and they can give immunoglobulin replacements and all sorts of things that can be done. Vaccinations. So I have to put here non-live vaccines, because remember, CLL patients are not allowed to have live vaccines, and there are unfortunately very clear cases when patients with CLL have had shingles vaccine. That's the commonest one because it's given to elderly patients. Most of them are fine, but there are clear cases where shingles has caused significant illness. So on our BSH guidelines, we've recommended pneumococcus vaccine. So Prevnar 13 is perhaps a more potent vaccine. In our guidance, we say Prevnar 13 followed by the pneumovax. Meningococcus and Haemophilus, these are other encapsulated bacteria that we know patients are more prone to getting. Haemophilus is typical one for chest infections, sinus infections, and we do recommend, or I in my clinic do recommend vaccination. There's a combined vaccine, Monitorix. I know it's not in the green book, and some GP practices are more keen and less keen, but I'm just saying the things that are out there. So Shingrix is a difficult one. So this is the new GSK vaccine. It's non-live. It's a very effective shingles vaccine, but it is not NHS approved. It got its European license in 2018, and there are various private vaccine centres that do offer this. And I know, if anyone's very keen, you can ask me afterwards. There's a couple of clinics who I've been sending patients to. But it's not cheap. It's about £400 or £500 for a Shingrix vaccine. It's 2 jabs. So vitamin D, that's often discussed, and it goes in and out of fashion as to whether vitamin D helps, and green tea, which is another one of these things that some people absolutely swear by. So vitamin D, there's been a lot of interest about vitamin D and immune function. That does vitamin D deficiency associate with compromised immune system? And there have been various studies looking at associated cancer risks. There have been trials trying to reduce cancer in women, older women with vitamin D intervention. And there have been reasonably interesting data sets across different cancers, breast, colorectal, lung, melanoma, suggesting patients who are vitamin D deficient do less well with cancers. But I did then have to show this, which was the VITAL trial, and this was published just literally a month or 2 ago. 25,000 patients randomized to getting vitamin D supplements or nothing, and studying cancer outcomes and cardiovascular outcomes, and absolutely no difference with 5 years of follow-up. So it's like all these things, there are real enthusiasts. And the advantage of vitamin D, as I say to my patients, you go to Tesco's, get your little pot. You can pop one of those 10 microgram tablets a day. I'm sure it'll help. Does it really help? I don't know. But there are some real fans who like it. And why are the fans there? Because of a couple of data sets. This one's from Tate Scharnefeld. It's a bit old, but they looked at their North American patients and said, how soon do patients progress? Let's look at their vitamin D levels and see. And what they found is patients who had normal vitamin D levels seem to stay in stage A for longer. Those with lower vitamin D levels seem to need treatment earlier. And they even had this suggestion of a survival difference. Now, it's very difficult because vitamin D levels co-associate with many things. And always being cynical looking at any data, if it's retrospective, this is not an intervention. They haven't given vitamin D to that lot and not to that lot. And this could just be a marker for people with a lower socioeconomic status in the States. It could be a marker for not having access to healthcare. You don't know what could be underpinning this. Or it could be that vitamin D is genuinely important. We don't really know. Green tea is the other one. So there have been a number of case control studies looking at the dietary flavonoid intake that comes from green tea, and suggesting that perhaps lymphoid cancers, not myeloid, but perhaps lymphoid cancers are reduced with green tea. And if you give concentrated polyphenol E, which is in green tea, and you give it to CLL patients, and that is equivalent to 1, 2, 3, 4, 5, a lot of tea, a lot of toilet trips to get anywhere near that dose of polyphenol E. But if you give it to patients, study them for 6 months, about 70% of patients did get a bit of response, shrinking of the lymph nodes, reducing of their lymphocyte count. Does that help? I don't know. But caution, in that trial, they noted minor liver inflammation. And I'm putting that picture of this poor chap. So this was on the BBC website in October. As some of you might remember, this guy who ended up needing a liver transplant from green tea supplements. Because it's a very important reminder that things that might seem good, and I'm not wanting to frighten people from their cures on the internet when someone will send them this and it promises them great thing, but anything you're putting in your body is a potential medicinal thing. And just because it comes from the leaves of a plant grown in the Tibetan wilderness or something does not mean it's natural and without problems. And you've always got to remember, capitalism, sorry, I'm going to sound like a capitalist here, it does basically work. And if the companies could make fortunes out of it, they would have done. And so I do believe that most of the things that people get and they self-medicate, most of them probably don't make a huge difference. That doesn't mean I'm saying don't do it, but just remember, there can be tragedies along the way with them. So we've touched on the things that push us towards treatment, so night sweats, fevers, lethargy, weight loss, falling performance status due to disease. That's something that can really creep up on people with CLL. And it's something that would be great if we could track it. One of my patients had one of these fit thingy watches and came in with a plot. This typical Cambridge patient, she brought it all in, mapped it out and showed this drop of activity. And we actually used that as a deciding thing to start treatment. Because this falling performance status, when people go, oh yeah, no, I used to go out, used to play 18 holes of golf last summer. I'll play a couple of holes now, but I prefer to go in. And that type of slow loss of performance is something that will push us towards treatment. And the troublesome nodes and changing blood parameters. But there's been an explosion of treatments. So we're moving in onto the treatment stage. So I started as a hematology, my first hematology job was back here in 1995, and we had chlorambucil, and fludarabine. And then occasionally you would transplant someone, and that was in the terrible, terrible days of allogeneic transplant in CLL. It's much better now than it was. And then there's been this explosion of new therapeutics that have completely changed how we can manage CLL. And it means it's now quite a strategic call. When you have somebody in front of you, age 65, and you're thinking, well, look, I'm working on a 20-year lifespan here. I've got to think very strategically, how are you going to move those pieces? Because it's not all just about first-line therapy. It's not first or second. And all sorts of things come into the equation. Tolerability, comorbidities. What's their heart like? What are their lungs like? Would they tolerate treatment that causes bruising or bleeding? Would they tolerate treatment that might make them more prone to infection? And there's a lot of thinking that has to go on. And what treatment options are there? Well, we've got different options at first line and relapse. We've got different options for fit patients and less fit patients. We've got different options now from what we're going to have in the future, quite categorically. And so when we think of them, we can broadly group them into 4 areas. So we have chemotherapy. We have monoclonal antibodies. We have B-cell receptor inhibitors. And we have BCL2 inhibitors. Chemotherapy. So this is the classic old-fashioned stuff that is non-specific and works by damaging DNA. And the basic principle of cancer is cancer cells are dividing quickly. And cells that are dividing quickly are replicating their DNA quickly. And therefore, any compound that damages the DNA will kill the rapidly dividing cell faster than it kills the slower dividing cell. And that basic principle has underpinned cancer medicine for years, because the idea is that you give some a slug of chemotherapy and hopefully the normal cells are okay. Well, their hair falls out if it's hair falling out chemo, because those are dividing cells. They get sore mouth and ulcers and diarrhea because those are the dividing cells of the lining of the gut, and they all get killed off by chemotherapy, or potentially get killed off. But it's that non-specific attack And as we've talked about earlier, some CLLs are much more sensitive and are killed off by CLL than other cells. One of the reasons 17p deleted patients are not killed off so effectively is because this DNA damaging thing is recognized by the TP53 protein. The product of that 17p gene goes out, sees its damaged DNA and triggers a death response. So if you don't have that protein, if you're 17p minus, you can damage your DNA, but actually the cells don't die. And you can already see problems that can come from that. You've got cells surviving with damaged DNA because your 17p network isn't working. Radiotherapy works in a similar way, but my radiotherapy doctors forbid me from talking about radiotherapy because my knowledge of it really is quite slim. Antibodies. So antibodies have been one of the revolutions in treating lymphoma and CLL over the past 10, 20 years. And rituximab is the most well-known of the antibodies. We now have obinutuzumab. We've got all sorts of new ones. We've got ofatumumab as well, not used as much, but new ones coming through the system. And antibodies are large proteins. Sometimes I describe them as the magic bullets that instead of chemo, which goes in as a small molecule, bashes up the DNA, these are big proteins that latch on to the surface of the cancer cell. And when they latch on, they kill the cancer cell in different ways. Sometimes it's direct, so it grabs all the proteins on the cell surface, locks them together, and it triggers death of the cell through a direct mechanism. Other times, it relies on something called the complement system, whereby it goes onto the surface of the cell and it pulls in these other proteins called complement, and they punch holes in the cell and kills them off. Other times, it uses the immune system, so the antibody provides a bridge to bring in other killer cells that then zap the leukemia. So antibodies are very clever. We know in CLL you get far better bang for your buck if you put the antibody with something else. So immunochemotherapy is antibody combined with chemotherapy. But the major breakthrough in CLL over the last 5 years or so, 5+ years now, has come from small molecules that target inside the cell in a very specific way. And that is ibrutinib and idelalisib. This is a picture of a B cell. And B cells are very dynamic things. And although they are cancerous in CLL, they still depend on signaling. So I don't know much about pancreatic cancer, but I always use it as my example of some terrible cancer that just grows and grows and actually becomes independent of its microenvironment and just carries on growing and the poor patient dies. Whereas CLL needs signals that come in from the immunoglobulin chains, and we call those the B cell receptors. And those signals are just coming in all the time and just saying, live, survive, don't die. And the CLL cells are very dynamic. They circulate around the blood, around the lymph, into the lymph nodes, into the bone marrow. And when they're in the bone marrow and the lymph nodes, they get this stimulation that says live. And it all comes down through the B cell receptor. So you'd have thought years ago we would have worked out how to target these. So it took quite a long time, and there's a lot of separate debate about that. But downstream from these receptors, we have all of these molecules, SYK, BTK, PI3K, AKT, and they're all, in effect, the proteins, the wiring that takes a signal down to the nucleus and says, divide and live, divide and live. And so I say to patients sometimes, well, ibrutinib and idelalisib, they're like trying to cut the wires from the light switch, because the switch is coming from here. Chemotherapy is someone takes a sledgehammer to the wall and sort of attacks it, pulls out the wiring. This one, actually, someone's gone in there and had a molecular switch. Now, that sounds like I'm a Janssen marketing person say that. Of course, it's far more complicated than that. But in effect, it is a way of very specifically switching off parts of the pathway. BCL2 inhibition. So there are these 4 families. Remember, I did chemotherapy, antibodies, B-cell receptor pathways, and then venetoclax. And this is a slide I grabbed from Andrew Roberts yesterday at the CLL forum session. So Andrew Roberts in Melbourne, they were instrumental of developing this drug. Amazing and hard to believe that it only went into a patient in July 2011. And already it has these 2 different license indications, monotherapy, combination, and is without doubt going to make a huge impact on how we manage CLL, but not just CLL and other cancers. So again, sorry, this is a little bit of complicated biology, so this is beyond you, just fall asleep and rejoin me in a minute, because I'm just going to have to explain apoptosis. Now, apoptosis is cell death. A biological organism cannot survive without cell death. It's like clearing out the rubbish. It's actually, I haven't thought about all this. It's like clearing out your recycling bin because you get the bits back and use it for your organ again. But when you're developing in the womb, you start off, say, with a webbed finger and it retracts back to having fingers. When you are a gut cell, you have new cells being made to constantly line your gut, but then other ones recycle and die off. It's all natural biology. And of course, a hugely important part of living is when a mistake is made, an abnormal cell is created, because remember, we have trillions of cell divisions have gone on today. Since you came to this, every one of you have had trillion cell divisions somewhere in your body just to keep living. But if a mistake is made in that process, the cells have to die. And so this natural cycling of apoptosis is going on all the time. And it is highly regulated. And not surprisingly, a recurring theme in cancer, whether it's pancreas cancer or CLL or lung cancer, is this failure of apoptosis. Because bad cells should die. Bad cells shouldn't keep living, but they do keep living. And there's all sorts of mechanisms high up in the cell. But there is this unifying thing down here where these pro-survival proteins and pro-apoptotic proteins get out of sync. And CLL has this very high level expression of this thing called BCL2. And BCL2 is a pro-survival protein. It stops apoptosis. So all of those B cells getting these abnormal signals saying live, live, divide, divide, they should be dying. But they're not dying because of BCL2. And we've known that for years in biology, and it's been the holy grail of trying to inhibit it. And it is an incredible story. The scientists who were working in Chicago at Abbott Laboratories, as it was, now AbbVie, spent decades on this project trying to work out how you can get a protein into this little slot here. Because the natural compounds which are working in life, these 8, they call them the pro-apoptotic BH3 mimetic proteins, they slot into this incredibly complex groove. And it was an amazing challenge of medicinal chemistry. And one day it will become a film, I'm absolutely telling you. Because this guy, I've heard him give his talk, and he says, you know, he was being shut down and his lab was reduced, and he said, just let me do one more experiment, and they'd have maybe one mouse survived in his experiment, so go on, you can do a little bit more. And so clung on to his group over years while trying to develop the techniques of getting these alpha helical protein sheets to cling together so they could go into this groove. And then along it's come. So this drug, venetoclax, slots into that groove. And it is a remarkable drug. And the reason it is remarkable is it kills CLL so effectively. And Andrew Roberts, presenting yesterday at the CLL Forum, was reminding us those first 3 patients who started on 200 milligrams, they killed all their white cells in their blood in 8 hours. And that's why venetoclax is such a potential drug and why you've got to start it at a very low dose. And we spend a month now building up to 200, 400 milligrams because you simply can't take it too early. So that's the introduction of the therapy. So we are going to talk a little bit about the treatment options which we're treating with. So remember, chemo, antibody, B-cell receptors, sort of ibrutinib type drugs, and venetoclax. And those are the 4 tools we're working with. So first line, non-trial in the UK, for fit younger patients, FCR, BR. Ibrutinib is licensed. It's not available on the NHS currently, and that is something that we were talking about a lot in the CLL Forum yesterday. And the current UK FLAIR trial for fit patients, which is randomising between FCR, so that's our toughest of our chemotherapy regimens, against ibrutinib on its own or ibrutinib combined with venetoclax. So what do we know about FCR and BR? Well, FCR is a more tough chemotherapy. in terms of side effects of delivery, chances of becoming unwell, chances of developing complications down the line. And I won't go into that in great detail, but FCR is more tough chemotherapy than BR. The Germans did a head-to-head trial in young patients, and they found when they asked the question, well, look, how many were still in a remission as the years passed? And the answer was very clear. FCR, more patients stay in a remission longer. So that is median PFS means progression-free survival of half of them. And it's a standardized way of looking at readouts from clinical trials. And you can see here, 13, 14 months longer for progression-free survival. But when the Germans looked at overall survival, they were completely overlapping. And they've been following that trial and asking, well, why did the FCR ones die and why did the BR ones die? And that's actually quite an involved talk on its own almost. But the take-home fact is that 3 years, around 90% of patients are alive. So 8–10% of patients have died by 3 years in the German young fit patient trial with FCR-BR. So that's a figure just to keep in your mind as we talk about the others. But the main push with FCR is the hope of these very long remissions. And we've got long follow-up of a few big sets of data. And it's hard to see at the back, but this top green line, which is stretching out, out towards 10 years, is patients with mutated immunoglobulins. Now remember we talked about prognosis? We said the ones that come from the mature B cells on the right-hand side. So IGVH mutated CLL having these very long remissions. And actually, if you look at the mutated patients and you ask yourself, well, the ones who got MRD negative, and we don't really have much time to talk about MRD, minimal residual disease, it's this big thing. So when you're treated, if you get a very deep remission, i.e. your leukemia is very sensitive, then those patients can have really long remissions. That's 80% of them still in remission at 15 years. And that does beg the question, well, are these patients actually cured? So if you have IGVH mutated CLL and you're fit, you might well say to your doc, well, actually, I want FCR because I'm going to roll the chances with toxicity and all the other things because I want to take my chance on being one of these patients. The MRD positives, so these are patients who still had some very low-level detectable disease. They still, 15 years out, 40% were still in remission. So IGVH mutated CLL, FCR still is quite appealing. But the unmutated, remember I said biologically those more primitive cells on the left-hand side, that's a bit harder to be as convinced by because the progression-free survival curves are going down, whether it's FCR or whether it's BR. So if you have unmutated CLL, if you're treated with FCR, yes, you might have a 6-month longer remission on average. But is it worth the extra toxicity if you are going to get a 6-month extra remission, but there is very little in the way of promise of a very long remission? And so that's a question that we are asked sometimes in clinic. I'm going to show quite a bit of data from ASH 2018. So ASH is the American Society of Hematology. It's our big global meeting that happens in December every year. And if people really get into CLL and the diseases, some of my patients, obviously in Cambridge, I have some of you academics and you track this data. And I've got to make note of when the abstracts go live in November because I know if I haven't read them by the first clinic, someone will be asking, what I thought of the 4th paragraph interpretation. Oh dear. But it's very exciting, keeps you on my toes. So what did we learn at ASH? We learned loads at ASH. It was a remarkable CLL ASH because we had 3 first-line prospective randomized trials presented. The Germans have an amazing trial, CLL14, that you have to look out for. There was no space for it on the program. Actually I'm being videoed here. A lot of Germans who were a little bit unhappy about their trial not being on the program, I'll say that carefully, but look out for the ASCO, the American Society of Clinical Oncology the abstracts will be coming out in a month or 2, so that'll be presented in June, a fascinating trial. So, let's look at the first one. So in this trial, this was ibrutinib against FCR. It was ibrutinib rituximab, but I don't have time to show you that adding rituximab to ibrutinib probably makes no difference. So it's probably best to just think of this as ibrutinib. And in this trial, patients were young, they were under 70, had to be fit enough for FCR. In the UK, FCR 70, that's pushing it a bit. Maybe we would ease off a bit below that. But anyway, up to 70, and patients were randomised to ibrutinib, rituximab or FCR, and this is their progression-free survival with 3 years of follow-up. And the patients given ibrutinib, 90% of them had stayed in remission. The patients given FCR, it was with double the amount of relapse, so about 80% stayed in remission. So that surprised people, because we all thought, well, FCRs are pretty good cutting-edge therapy. It's going to be hard for ibrutinib to beat it. That's progression-free survival. What surprised people even more, oh no, that's the next slide, sorry, I've jumped ahead. The mutated, unmutated, that did not really surprise us very much. So mutated CLL, quite hard to separate the two. Remember what I said to you, that FCR does much better with mutated? Unmutated CLL, one of the recurring themes of the newer drugs, whether it's ibrutinib or venetoclax, is actually unmutated CLL. It just doesn't really matter. They seem to do equally well. And that's illustrated beautifully here, that you've got 20 of 210 relapsing with unmutated, and then with mutated, you've got 8 of 70. It's basically the same number. So whether you have ibrutinib with mutated or unmutated doesn't matter. But FCR with unmutated falls down the curve. And this is why in the States, even before this was produced, the unmutated CLL, they just simply wouldn't give chemotherapy to. But we do not have that capacity in the UK. What really surprised ASH, the entire conference was surprised by this, was the overall survival figures. And they're surprised for a number of reasons. So you can't see these numbers at the back. Ibrutinib, there were 354 patients in this trial. Only 4 patients died with 3 years of follow-up. Now, that's a 1%, 1.2% mortality at 3 years. You do have to ask what the natural life expectancy is for a group of people. You can't live forever. Human beings, we do all unfortunately die at some point. So there is natural death within the trial, but that ibrutinib death rate was strikingly low. Sometimes in trials you think, oh, maybe the standard arm has done badly. Maybe that's emphasizing the experimental arm. But no, if you look at the death rates on FCR, 10 deaths out of 1750, that's about 5–6% death rate by 3 years. That's actually lower than the FIT German trial death rate with FCR. Probably because many patients can be salvaged, we've got new therapies. But that was a real sit-up and look moment at ASH, that ibrutinib first line for non-17p deleted patients, how striking that was. So what about less fit patients? Well, our options first line are chlorambucil obinutuzumab, bendamustine rituximab again that we've talked about, and ibrutinib. And again, I have to put that there, that for non-17p deleted, ibrutinib is not yet NHS commissioned. And the current UK trials are bendamustine rituximab, so that option being randomised against the Chinese ibrutinib, which is called zanubrutinib, which has some advantages in some ways, but we do have to see how it pans out in trials. So what do we know about obinutuzumab chlorambucil? That is a very popular standard of care. So obinutuzumab is the new Roche antibody, and in the randomised trial of obinutuzumab chlorambucil against rituximab chlorambucil, the obinutuzumab was better. So this was the first head-to-head data telling us in CLL this new antibody obinutuzumab is better than rituximab, and that's impacting a lot on trial design because obinutuzumab really is the new partner for a lot of these drugs going forward. But you'll see that progression-free survival, half of the patients had relapsed by about 27 months. So these drugs, obinutuzumab chlorambucil, is not as effective as rituximab bendamustine, but it's a bit less toxic. So it's quite appealing to a lot of patients. Now at ASH, I said there were 3 first-line randomised trials. The 2 others were in the less fit age group. Now this is comparing ibrutinib against obinutuzumab chlorambucil. So this is our frustration, of course. That is our dotted blue line, which is our commissioned therapy in the NHS, and you can see this huge difference in progression-free survival. So patients taking ibrutinib tablets have a markedly higher chance of still being in a remission than those given chemotherapy plus antibody. Now, and the high-risk patients, so those with actually not 17p, but who are unmutated, 11q deleted, etc., the difference was enormous, very striking difference. But when survivals were compared, absolutely overlapping survival. And why is that? Because 46 of 116 patients, so 40% of patients, had converted onto ibrutinib. Now, you could look at that in two ways. If you're a healthcare provider counting costs, you'd say, well, hang on, there's no deficit here, because you start everyone on the cheaper combination. 60% of them haven't needed ibrutinib, whereas if you start everyone on ibrutinib, 100% need ibrutinib. So you can see where the logic of the maths is. Not necessarily thinking the ones just had tablets where others have had to have chemotherapy and infusions. But that wasn't the only other frontline trial in the less fit. And also presented was the trial of ibrutinib against bendamustine rituximab. So this is a huge amount of data. I'm looking around the room. Some people are going a bit blank, but we'll stick with me. We've got to have it so we can have discussion at the end. So in this trial, they were ibrutinib or ibrutinib rituximab. So those are the two combinations randomized against bendamustine rituximab. And again, this surprised people quite a bit because this is progression-free survival, and you can see there's a very clear benefit, ibrutinib winning out. But this did surprise people. When they looked at the overall survival for this one, now, I don't want to jump and overinterpret those curves, but the black curve, the better one, was actually bendamustine rituximab. And the lower curve, the ibrutinib, actually seemed to have this slightly excess early mortality. And it's not entirely clear why. And it is still unclear why. Deaths up to 30 days after 6 cycles, 1%, 2%, 3%. There's discussion about cardiac toxicity with ibrutinib, and it is clear that certain cases have been presented, not just atrial arrhythmias, but also ventricular arrhythmias. They are almost certainly rare. Are they more common in elderly patients? Are they more common with comorbidities? So ibrutinib definitely has certain questions left unanswered. In terms of side effects, ibrutinib clearly has fewer side effects than traditional chemotherapy in the way that you might think, the nausea, vomiting or hair loss or admission to hospital with complications and all those things. But it has its own side effects, bleeding, bruising, risk of atrial fibrillation, and this rare thing, ventricular heart rhythms, that we don't really have a clear feel as to how common it is. 17p deleted CLL, I haven't really touched on it. Undoubtedly, ibrutinib is still the standard of care. So ibrutinib monotherapy is how you start treating patients with 17p deleted CLL. That is NHS commissioned, and it is a standard of care. One of the reasons why every CLL patient needs to have sequencing of their genes before they start first treatment is about 5% of CLL patients have this hidden abnormality in TP53, and you'd only find it by doing the sequencing of the TP53 gene. And that's very important because then we can get them the ibrutinib on the NHS. So that's all first line. Then relapsed CLL. So retreatment with chemotherapy and antibody therapy. That has become much less appealing now, and I'll show you the reason why. But that is always an option. You have some patients who really tolerate chemotherapy absolutely fine, and they have no problems, and they will have 4, 5, 6, 7-year remission. Their disease wakes up and they say, look, why can't I just have another burst of chemo again? Because that fits with them. They do not want to take ongoing tablets. They don't want to be coming back to the clinic repeatedly for the next 5 years. And of course, so there are the odd patients out there for whom that is appropriate. But treatment with one of the novel therapies has definitely taken off as the international standard for how you treat relapsed CLL. And really, the big debate in our clinics now is going to be between ibrutinib and venetoclax combined with rituximab. I've put idelalisib there in brackets because it's less appealing due to toxicity. So idelalisib really has fallen a bit by the wayside. There are a number of other drugs which are coming up close behind. AstraZeneca's remarkable BTK inhibitor, acalabrutinib, is looking really very interested. We've used that a lot in clinical trials in Cambridge. And there are other things. There's another PI3 kinase inhibitor from this company, TG Therapeutics. Very good, used it in trials, looks very interesting. So there are lots of things that are coming. The bad old days. Relapsed CLL used to have terrible survivals. And this isn't so long ago. This is from the MD Anderson, so the cutting-edge cancer center in the States. And this is showing average survival with patients refractory to CLL, so refractory to fludarabine, sorry, so where fludarabine is not working, the chemotherapy has stopped working. Average survival only 10 months before ibrutinib came along. And then along came ibrutinib, and this is just a bit of a CLL forum plug. I chaired the forum for 4 years, and as part of that we set up this big data collection from across the UK, and I'm sure there's a chance someone in this room has their survival stats have been plugged into this, which has been very, very powerful and influential, because one of the things that when we go to NICE, and I was on the NICE panel as one of Peter Hillman and I were their professional advisors, that they want to see what are the real world figures, what happens in the UK. We're not a US cancer centre where people have been selected because they can fly 2,000 miles and give a credit card down payment of X. This is the real world in the UK, and that's why this data was important and why it's remarkable, because with ibrutinib used in very difficult patients, so relapsed refractory, median 3 prior lines, a lot of complications, not selected by being healthy and fit enough for a clinical trial, literally just given to the people in the clinic. These amazing things. So 55% still taking ibrutinib at pushing 3 years, and we're going to update this survival data for the international conference in Edinburgh at the end of this year. There are some cons with ibrutinib and idelalisib. Some patients can have side effects that can be quite complex. Ongoing therapy, it raises this question, and again, it was a theme in some of the CLL forum discussions yesterday. Biologically, is it right to keep exposing your CLL for a long time? We just don't know. The companies are not known for designing trials with stopping criteria. I can't imagine why. They design trials where you take the drug, and if you're well, you just stay on the drug. But if you were in charge of that drug and you were making no profits from it, you might start your trial design with, well, let's have arm A that takes it constantly, let's have arm B that takes it for a year and then stops, or let's have arm C that if you've done really well, you stop and you restart it if they develop any abnormal cells coming back. So those are all appealing, but they're all experimental because we just don't know. We don't know if you're really well at 3 years and you stop your ibrutinib, it comes back and you restart at 5 years, will you go back to the same remission? We just don't know. And of course, if a patient's taking the drug and they have no side effects, it's very hard to turn around and say, stop it. But we just don't know. And trials are tremendously exclusive. The companies are always saying, oh yeah, no, we want to have everyone in the inclusion, but you actually look and you're excluded if you've had a prior cancer. Lots of elderly people have had prostate cancer and they might find themselves excluded, or you had breast cancer chemo, and sometimes it's excluded 3 years, sometimes 5 years. Performance status excludes people. If the kidneys or the liver are looking a bit ropey with age or something, they can be excluded. So trials are difficult. But then getting access to the drug itself can be difficult. And this was a letter that Peter, Anna and I and a bunch, and Claire from the Marsden, we published in the Times last May, because there was that big scrap that took off that one of the Times journalists, who's a CLL patient, very open about his condition and has written very emotive and persuasive arguments. He relapsed, but he was a late relapse, so wasn't allowed access to ibrutinib. And this was a very powerful catalyst for putting this debate in the public domain, and this letter we put together into the Times. And actually, NICE moved, NHS England moved on this point. And so using ibrutinib for late relapsing patients is an option. We weren't saying it had to be there for every patient. We were just saying it was simply wrong, because NICE had said that we could use it for late relapsing patients. They didn't put any restriction, but NHS England had put an extra layer of restriction. So it's quite complicated behind the scenes with commissioning and what is actually allowed. So why do patients stop ibrutinib? I do get asked this question. I've started on this drug and said, do I take this now till I drop dead? And you go, well, it's an open-ended therapy, and then you end up getting stuck in a question, why do people stop ibrutinib? Well, sometimes infections. Sometimes side effects. There can be side effects that might be relatively minor, but if a relatively minor side effect goes on and on for a year or two, some patients might just get fed up and want to stop it. Second cancers, that might preclude them from continuing drug. Of course, progressive disease or transformation to that dreaded Richter's, that can happen, and that's another reason why people come off drug. But I've put other unrelated, and will some well patients simply decide to stop? I suspect they will. We know in the States where there's a lot of co-payment, so depending on your insurance plan, you might have to pay 20% of your drug costs. There's a lot of, mysteriously, there's a lot of dose reductions and stopping of ibrutinib. But what happens when patients stop? Well, it's heavily influenced as to why they stop and what other access of drugs we have. And now that we've got access to venetoclax, then we are stopping people a bit earlier. Because actually, if you've got access to other effective therapies, if somebody is struggling more with ibrutinib, it's simply unfair to keep them on if they've got side effects they're not tolerating, or if they're relapsing, but okay. That British way of, oh, we'll give you another 3 months, see how you get on. Actually, that's probably not right if you've got other drugs that you can use. And we know that venetoclax, when used as monotherapy, so this is a small data set, but shows this remarkable thing, 2 years, an average of staying in remission with venetoclax after ibrutinib. So this is patients who came off ibrutinib, and these really quite long survivals. But the really big trial in relapsed CLL at ASH was the 3-year update of this Murano trial. So this was a large randomized trial where patients were either given venetoclax rituximab, so that pro-apoptosis drug combined with the antibody. They were either allocated to that or they were allocated to bendamustine rituximab. And this is the first time one of the newer drugs had actually been randomized against immunochemotherapy, because the ibrutinibs and idelalisibs and all these things, their development path, they'd been randomized against monotherapy antibody, ofatumumab or rituximab. So in trial design, there'd always been this niggling thing at the back of your mind saying, well, ibrutinib has never actually been trialled against proper old-fashioned immunochemo, and maybe immunochemotherapy might be better in those late relapsing, maybe, we just don't know. But then along came Murano, and this told us absolutely categorically that this new approach, venetoclax rituximab, was better than bendamustine rituximab. And this is a time-limited therapy. So you get the venetoclax and rituximab for the first 6 months, and then you take venetoclax to the end of 2 years, and then stop. And what happens to those patients? Well, that's the progression-free survival, so that's the number staying in remission, and you're up there, sort of, this is 4 years out in relapsed refractory CLL. And quite a lot of these patients had multiple lines of therapy, and you've got 80% of people still in remission. Whereas bendamustine rituximab, you're down in the 10% territory at 3 years. So a huge difference in chance of whether you'd stay in remission. And then, despite access to all these newer therapies that you can cross over to, there was still this survival difference between venetoclax rituximab and bendamustine rituximab. There's some statistical quirk about how this is interpreted that I won't get stuck into. But in really simple terms, if you're sat there in clinic with your patient and you've got a choice between the blue line or the green line, it's hard to choose the green line. And I mean by that seriously. So even those late relapsing patients, if you relapse at 5 years, you would need to persuade me quite hard that chemo was better for you on the green line than the blue line. And one of the other criticisms being, well, hang on, we don't know what happens to these patients when they stop venetoclax. Because if you've had this 2 years of therapy and then stop, maybe they all relapse. They just crumple in a heap as soon as you stop the drug. But that's now been shown not to be the case, because this is with an average follow-up of 10 months. And you see up there, 90% of patients are still in remission. So, of course, it's relatively short follow-up, but the patients are not all relapsing. So, short course targeted therapy, stop, and many patients are remaining well. And this is a little bit of detailed analysis. I wasn't really talking about MRD, but the green is good, red is bad, and this is the end of 2 years of treatment. You've got about 2/3 of patients coming off that combination in very deep remissions. And those 2/3, when followed for this nearly a year, 10 months, only 1 patient out of 80 had actually relapsed. So pushing people into proper deep remissions that are very, very tenable. They hold on to them. And this is what's persuaded NICE. So NICE originally pushed back on venetoclax rituximab. We weren't entirely sure why. There was a lot of unhappiness about this, but essentially I think they were holding out for the 3-year data, which we now have, and now it is recommended. So as of a few weeks ago, with relapsed refractory CLL, you are able to have venetoclax rituximab in NHS practice. And so that is the big decision in the clinic. So we now have ibrutinib and venetoclax rituximab. So we genuinely have decisions to make. And there are all sorts of pros and cons of each approach. And any of you who are in that circumstance will have to discuss pros and cons with your CLL clinician to make sure you sort of choose what is right for you. But both are available. And that's really me coming to the end of the talk. There are many areas of CLL biology and treatment I obviously haven't been able to cover just in one straight talk. We haven't really touched on MRD and using minimal residual disease in treatment and routine practice versus trial. Allogeneic transplant, haven't mentioned at all. CAR T cells, this amazing immune therapy. I'm delighted that Cambridge and Leeds have been chosen as 2 of the 11 European centres for the CAR T cell trial that will be starting Q4 this year. There are very specific tight entry criteria, and it will be super selective, super fit patients who will go into that trial. But it is this new, completely different way of attacking cancers by using the patient's own immune system, which is something we haven't been able to touch on. I haven't really talked about the side effects of the new drugs. They've all got their quirks and their ways of getting around that. I haven't been able to touch on these combinations, obinutuzumab, venetoclax, ibrutinib, remarkable data. But if you are wanting to watch this space, check out the German CLL-14 data, obinutuzumab and venetoclax. And I have not seen that data. I'm just making sure from my public statements I've not seen that data. But let's just see what it shows us. And then the other new drugs that are in the pipeline, I touched on acalabrutinib, the AstraZeneca drug, and BeiGene's Chinese drug, this zanubrutinib. Very, very interesting, cutting down on some of the side effects with ibrutinib, and we have to see, are they going to be as good? They may well be. And then I think that is where I'll call it quits. I'm very happy to take questions from the floor. Thank you.
Thank you very much.